So Len, let me turn to you and ask you to speak a bit about both the thinking that you have done and some of the efforts you've been engaged in to execute on real boots on the ground partnerships with both public and private sectors, and how you think about financing and payment for whole health.
Well, Mai, thank you. It's a privilege to be here and be on any panel you organize. So thanks for the opportunity. I will start with a statement that may seem uncontroversial for an economist. You get what you pay for. You get what you pay for. It's a commonly used phrase that usually implies that true value and price are highly and positively correlated. And sometimes, maybe often they are. But you get what you pay for can also implicitly mean the converse. You don't get what you don't pay for. And this interpretation seems more apropos of our discussion today, since, as others have noted, our fee-for-service driven system of paying health service providers for the things that get them paid, and our bigger-than-neighbor system of mostly not paying for social services that profoundly shape the health and life chances of so many, have, along with worsening opportunity inequalities over time, conspired to make literal beggars of too many of our neighbors. So what is to be done? We need to pay smarter, put that in quotes, which is perhaps a bit glib to say, but maybe not so hard to do as some people think. Pay smarter starts with the ultimate payers, public programs, employers, citizens, workers, taxpayers. But pay smarter also has rather specific implications for folks near the front lines, like insurers, clinicians, community-based organizations, local government units of various kinds. Let's start with health providers. Not to belabor the obvious, but time and work that improves health is not the same thing as RVUs. Yet our health system mostly pays for RVUs and procedures. And this disconnect between value and payment is not the rank and file clinician's fault. The RUC and the long lost good intentions in the RVRVS system come to mind. But the sooner we move toward value-based, non-fee-for-service centric payment, with all due respect to Tim, the better. Properly value-based payments would free clinicians from the RVU hamster wheel and listen and to learn more about their patients' whole lives, some facts of which are highly relevant to their health. But at the moment, most clinicians are or feel impotent to address these social needs, and so they underinvest in finding out about them. But those social needs are far too often actually not someone else's job. It would be if CBOs could be connected to the right patients or residents at the right time, and if there was funding to pay for the social services these folks need. So in my view, paying smarter means at least two things at the whole person level: paying for health-related social services themselves and investing in the connection infrastructure we need to make a health and social service ecosystem truly thrive. Let's start with the health services themselves. Or health-related social services themselves. Who should pay for them? About a year and a half BC, before COVID, Lauren Taylor, who's now at NYU Medical School, and I published a health affairs paper that argued many health-related social services are like public goods. They benefit the recipients themselves, of course, but they are also likely to improve health and lower healthcare costs for insurers, providers, as well as possibly improve employment, school, and law enforcement outcomes, which in turn benefit governments and taxpayers at every level. If multiple organizations benefit from an activity, the activity is likely to be undersupplied because of what economists call free rider behavior. I won't invest in X since I can get the benefit of your spending on X. But if everyone adopts this narrow, self-interested attitude, then no one invests in the health-related social needs, save philanthropies, and God bless them, everyone. Lauren and I, with the support of the Commonwealth Fund, Episcopal Health Foundation, Missouri Foundation for Health, and Colorado Healthcare Foundation, have built on that paper and developed a model we call CAPCHI, the collaborative approach to public good investment, that is now being implemented in 3 locations: Cleveland, as Don said, Albany, and Waco, Texas, with as many as 6 more possible implementations in the next 12 months. The essence of our model is to channel mutual self-interest into a shared funding stream that is adequate to sustain the scale of social services that's desired by the collaborators. One key prerequisite for this to work is that each member of the local stakeholder coalition must recognize that while they will gain from their investments or payments, others will benefit as well, and they have to be okay with that. They have to agree to pursue, in other words, enlightened self-interest rather than the narrow self-interest of free rider behavior. Somewhat surprisingly to me and to others, there is actually over 30 years of work in game theory that supports this approach. And we are now watching community coalitions around the country agree to adopt enlightened self-interest as an operating principle. This counts as an advance in capitalism and certainly in community health, in my humble opinion. But there aren't enough healthcare savings to pay for utopia, which gets me to the role of insurers and public programs, including non-health programs. Partly due to the growing body of work tying timely social services to health improvements, and of course, intensified by the glaring inequities revealed by COVID and Black Lives Matter last year, health plans serving public program enrollees are actually increasingly focused on learning about and paying for upstream services that work, where the definition of work means counts in an MLR and reduces health costs somewhat. Now, recently, CMS for MA plans and state Medicaid programs for Medicaid MCOs have liberalized and clarified which social services count in these ways. But there is still considerable room to improve in this domain, and perhaps we can get into specifics in the Q&A. But for now, I want to wrap up my opening remarks with 3 points. Point 1, if we're going to pay smarter, we need to get smarter about how we think about the value of health-related social needs. I am not the first person to point out we never demand that a new drug completely offset its astronomical launch price with hospital or ambulatory spending reductions, but serious people do argue against healthcare paying for social services unless the health spending offset is complete. This is myopic, not enlightened self-interest. If a social service improves health, likely through reducing avoidable stress or enabling life-enhancing activities to take place, it is just as valuable as many CPT codes we could all name. If it reduces health costs at all as well, that should be gravy, not a prerequisite. And if it does completely offset healthcare costs for some patients or more so, then not covering the service through insurers' MLR is a sin. Now, we can argue about the generality of some of the SDOH evidence, but I do think we need to adjust our priors on the right standards to apply to that growing evidence base. Point 2, if we're going to pay smarter, we're going to have to pay more for the connective tissue or infrastructure of our many local health and social service ecosystems. These new technology platforms like Unite Us, Healthify, Ambertha, NowPow, and some homegrown ones created by 211 San Diego, CIE, the Quality Health Network in Grand Junction, the Alliance for Better Health in Albany. These can all be part of the solution, like the bones of a railroad track and switch controls that can speed referrals and feedback loops. But the flesh and muscle and heart of a local ecosystem is a network of relationships among CBOs with specific local knowledge of what their clients need and how to address them, and between CBOs and healthcare organizations, local government agencies, and philanthropies. These relationships can be facilitated by contracting, curation, and communication standards that must be developed collaboratively and perhaps implemented through network lead CBOs, which can lower transaction costs for all concerned. And yes, this connective tissue infrastructure is like a public good. So for it to be adequately financed, it must be collaboratively financed. CAPG's one model, outcomes-based investing or social impact investing is another. And additional variants are being explored and implemented in communities across the country right now. I find those pioneered by the health system known as Common Spirit out west to be among the more promising. But the larger point is, if we truly want to achieve a decent standard of whole person care, we must collaboratively and adequately finance this public good called infrastructure, and we must start this afternoon. Point 3, braiding and blending, a beautiful metaphor for how long siloed public programs dollars may be combined to further common missions and serve actual citizens far better. The classic example is enabling Medicaid to pay for air conditioners for parents of asthmatics. But this braiding and blending must be part of a paying smarter solution. I would humbly call for a very focused White House-led interagency task force on braiding and blending oriented to social determinants of health. where the first task would be for OMB and the agencies to clarify in guidance exactly which program funds could be combined and how under current law. There's a lot more than most people know. And the second task would be to identify statutory changes based on current research evidence that could enable even more beneficial break-even to take place. After these changes are clear, then we can revisit how much non-health spending should be increased to make our society truly great for once. Thank you.